Welcome everybody to yet another town hall by popular demand. This is our second edition of the Wave 6 special on COVID-19. I wish to begin though with a land acknowledgement. We acknowledge that we are located on the Haldeman Tract, traditional and unceded territory of the Anishinaabe, Haudenosaunee, and neutral peoples. This land is part of the Dish with One Spoon Treaty between the Haudenosaunee and Anishinaabe peoples and symbolizes the agreement to share, protect our resources, and not to engage in conflict. It encompasses 950,000 acres of land that was given to the Six Nations in 1784, 10 kilometers on each side of the Grand River. This land was intended to be leased to settlers, but in some circumstances was sold as land with full title. Across all the Haldeman Tract, there were very few outright legal sales of land, and 90% of the leased land has never been paid for or paid to Six Nations. If you are not from the region, we encourage you to research the history of the land that you live on and the treaties that are tied to the land. We are all treaty people, and it is our responsibility to honor all our relations. Let's just pause for a moment to reflect on this in a meaningful way for each and every one of us. So tonight, we're very fortunate to have a program filled with many wonderful experts. On the agenda first is Dr. Sharon Ball, who is the primary care lead for Cambridge North Dumfries and the Waterloo Wellington Community COVID lead. She will be speaking to us about COVID-19 in Ontario and Waterloo Wellington. Next on the agenda, a discussion about COVID-19 antivirals with Kelly Grinrod, who is an associate professor at the University of Waterloo School of Pharmacy. Next will be what to do if you're experiencing COVID-19 symptoms by two family physician colleagues, David Sheik, who is a primary care lead in Guelph, and Sean Gartner, a family physician in Kitchener-Waterloo. Each of them have experience in the COVID assessment centers. Finally, we will have hopefully the most interactive and meaningful part of the evening of answering your questions with the presenters and some additional panelists who are available, who include Kevin Stinson, who is the program manager, infection prevention and control at St. Mary's Hospital, and the Waterloo Wellington Regional IPAC Hub Lead. We also have Kathleen Demers, who's the director of the Emergency Department CHESS Program and Integrated Comprehensive Care. She also oversees the Clinical Assessment Center. We have additionally Vicki Murray, who is the Integrated Director of Pharmacy Services at Granborough Hospital and St. Mary's General Hospital. This is being brought to you by the three Ontario health teams of Waterloo Wellington, Cambridge North Dumfries, KW4, which is actually short for Kitchener, Waterloo, Wellesley, Wilmot, and Woolwich, and the Guelph Wellington Ontario Health Team. Now, I understand some people are joining or will be watching who are not familiar with this concept. Just briefly, Ontario Health Teams are teams made up of many, many partners in the community, which includes really every sector of healthcare: hospitals, long-term care, primary care, community care, palliative care, all sorts of other social agencies and outreaches into the community, all working together And I think they've been forged a lot through this pandemic to help aid with the pandemic response with testing, vaccinations, treatment, and really forwarding new thoughts and ideas. So we're extremely fortunate to have an excellent panel of presenters, as well as those who will be answering your questions. So to start us off, I'm very pleased to introduce my good colleague and friend, Sharon Ball, who again is rock star from Cambridge North Dumfries. Sharon.
Thank you very much for that intro, Dr. Lee, right back at you. So this is how I'm sure many of us are feeling at this point as we enter that sixth wave, as we experience COVID, and that's been going on really for 3 calendar years now. It can be accompanied by a sense of, isolation, certainly lots of sacrifice, something that we've been through together and that feels like has been going on a long time. And so we are really wanting this town hall to provide hope and information and lots of knowledge moving forward. There's lots of things we can do to keep ourselves safe and healthy. So this is a Region of Waterloo slide from Public Health, and it'll be followed by one from Guelph. And really it speaks to the fact that COVID is still here. You know that living in this community, that COVID is actually present and circulating in our communities still. What's interesting is in the mid to late part of December, the number of people who could get tested changed. And so only certain groups of people were eligible for testing. And really, if you had symptoms, you were assumed to have COVID. So we could not really rely on just this purple curve here to tell us how much COVID there is in the community. We really had to combine that with how much COVID virus there is in wastewater. And what we saw is that the wastewater signal did follow fairly closely the activity in terms of COVID cases in the community. Right now, we're between about 16 to 19% of people tested in our region for COVID actually being positive. So really a fair amount of COVID still. But the good news is that in some areas we may have reached the peak, and actually it looks like we are plateauing, which is really wonderful news. And same trends here in Guelph. You can see that there's the wastewater signal, which sort of follows the general pattern of COVID cases, and that we are starting hopefully to see a plateau. The biggest piece around why we've had so many public health measures and restrictions has really been to ensure that we kept our capacity in healthcare. And that means really watching our capacity in the hospital. This is why we really want to contain spread. And right now, we have still have people coming in, being admitted to the hospital with COVID, but we have an additional situation, which is really that of backlog. We are seeing people who are sicker, who've delayed their care or had their care delayed because of COVID in many cases, and those who have been affected by the backlog of millions of procedures. So we really have to do our part to ensure we don't burden our healthcare system, and my colleagues will speak more about that soon. So we've moved from mandatory measures, strict measures in public health to recommendations. But we still are looking at kind of a 3-layered strategy. Masking continues in those highest risk settings. Vaccination and the need for 3rd and 4th doses is an important part in terms of us keeping each other safe. And of course, therapies is very important. So I have one slide on masking. Many of you may know that the provincial masking requirement was to actually end today, April 27th, but has been extended, I think very appropriately, to June 11th for our highest risk settings. So that means if you go to the doctor's office or to the hospital, you get services from home and community care, or you go to a laboratory, you and of course the staff will need to be masked. And that, of course, extends also to those communities or those settings that have the most vulnerable, like our long-term care homes, as an example. The next part of our 3-layer strategy is vaccination. And that's something I want to spend a little bit of time talking about. On the right, you'll see the region of Waterloo statistics, and on the bottom, you'll see those from Wellington, Dufferin, and Guelph Public Health Unit. And while for 12 plus, you can see there we're close to 90% with 2 vaccines. 18 plus, we're over 90% in the province in terms of people receiving 2 vaccines. We certainly have some work to do to get people boosted, to get those who are eligible, 12 and older, if it's been enough time to get their 3rd dose, those are who are immunocompromised, or 60 and older getting their 4th doses. That's quite key. As we see immunity wane, we have to make sure we get boosted. And, we're often asked as healthcare professionals that why are we seeing people in the hospital if they've been vaccinated? And what we need to remember is a very small proportion of the population hasn't had those 2 vaccines, less than 10%. But when you look at the number of people who are in the hospital, it's much, much more. They take up much more of the pie. And that's because your risk of becoming hospitalized if you're not vaccinated or if you've only had 1 dose is disproportionately much higher. Again, speaking to the importance of vaccination and how it prevents serious illness and death. And you'll see the same pattern in the ICU. So really, masking in those high risk settings and really in indoor settings where possible is important. Getting boosted is important. And of course, the reason all of you are here is about therapies. And that's actually something I'm going to pass on to our wonderful colleague, Dr. Kelly Gindrad.
What I'm going to talk about today is Paxlovid, but also I'll touch on other treatments for COVID as well. So not just Paxlovid, but that's the focus. Next slide, please. So everything I'm going to say here is in this document. So this is a frequently asked questions document that we prepared a little while back. It's on the uwaterloo.ca/pharmacy website. And when I'm done talking, I'll pop this in the chat as well so that you've got the link. But everything is here. Next slide, please. Okay, so what is Paxlovid? Everybody's talking about Paxlovid and these antivirals right now. So Paxlovid has 2 drugs in it. The first is called nirmatrelvir, and nirmatrelvir stops or slows the virus from making copies of itself in your body. So it stops the virus, the virus maybe gets in through your nose or gets in through your mouth or your throat. And when you take this medication, it stops the virus from spreading into other places in the body or increasing in numbers. Now, the trick with nirmatrelvir is it's a little bit hard to get a high enough level in the body for it to work well. So we use something called a boosting agent, or ritonavir. And ritonavir is just there to give us higher levels of nirmatrelvir in our body so it works well. So the goal of using Paxlovid and some of the other ones I'm going to talk about is that when you have mild COVID symptoms, you take this to stop or slow that viral replication in your body, which prevents the inflammation and that all this, the bad stuff that happens with severe COVID, right? Inflammation in the heart, inflammation in the lungs, inflammation in the liver and the kidneys, all that kind of stuff. You're trying to use this to prevent mild COVID, which you would have, from becoming severe COVID. Next slide. So one of the big questions is, who should get access to this? And so there's very broad general criteria right now for people who can be tested, who can be assessed. Generally speaking, and it varies province to province, but generally speaking, if you're someone who is not yet vaccinated, maybe because you couldn't be or you chose not to be, or you've only had 1 or 2 doses, you should be assessed for treatment. Now, you might not benefit from treatment, but you should be assessed. If you're over 60, you should be assessed. If you have a weakened immune system, so it might be a specific immune condition like common variable immunodeficiency or HIV, or it might be because you take a medication that weakens your immune system, something like chemotherapy or transplant meds, or certain medications for things like rheumatoid arthritis, for example. So people who have a weakened immune system should be assessed if they get COVID. And then there's other risk factors if you get COVID that make you more likely to need hospital care. Obesity is actually a really consistent one. Diabetes, lung disease like asthma or COPD, heart disease. I could be having a heart attack in the past or having heart failure, for example. Liver disease, kidney disease, cerebral palsy, intellectual disabilities like Down syndrome, sickle cell disease. So depending on your age, you might, having one of these might give you a much higher risk, or you might need to have multiple. Also, people who are pregnant, especially people who are pregnant who are unvaccinated, are at much higher risk. So if you have one or more of these, and the more of these you have, the higher your risk is, you should be assessed. So if you develop symptoms like fever, cough, with Omicron, it's really common to hear the sore throat and headache are pretty common symptoms. Within 5 to 7 days of developing those symptoms, you should be assessed. The 4 treatments that you may be offered include Paxlovid or remdesivir or fluvoxamine or budesonide. I'm going to talk about those 4 a little bit in a minute. Now, there's a few things you need to do. So you really need a test to find out that you're positive. You might do a test at home because you've got lots of rapid tests hanging around. If you get a positive test, that's great. It's most likely positive. If you get a negative rapid test at home, though, they're not always great at catching COVID. So you can have false negatives. So even if you have a negative rapid test at home, you might still be sent for a PCR. So let's say you get a positive test, maybe it's at home, maybe it's you went and got a regular PCR test at the clinic, and you are positive and you have symptoms, then you can be assessed for treatment. Your family doctor might assess you, the pharmacist might refer you. You can find out how to get assessed through telehealth or the COVID assessment centers, and we're going to hear from some of the physicians that work there shortly. Okay, so next slide. So there's 4 treatments, like I said, for COVID. So there's Paxlovid, which we've already talked about. That's an antiviral drug that you take by mouth, and it stops the virus from making copies of itself in your body. There's remdesivir, which is an antiviral drug that you get intravenously. So you get that through a needle, through an infusion. Just like Paxlovid, remdesivir also stops the virus from making copies of itself in your body. Fluvoxamine is a funny one. It's an old antidepressant medication that has anti-inflammatory effects. And like I said earlier, when the virus makes a lot of copies of itself in your body, one of the things it causes is inflammation. And it's the inflammation that's really dangerous. It's the inflammation that causes severe COVID. So fluvoxamine, this antidepressant with some anti-inflammatory effects, has actually been shown to have some benefit in reducing the development of severe COVID in people who have mild symptoms. The last one's a bit funny. It's budesonide. It's a common inhaler, Pulmicort. It's often used to treat asthma or COPD. The first 3 that I talked about are all aiming, if you have mild COVID, to prevent you from getting sick enough that you need hospital care. Budesonide is the only one, the budesonide inhaler is the only one that actually has been shown to help you resolve your symptoms a little bit faster. So that's not really what the other 3 are doing. They're trying to prevent you from developing severe illness, whereas budesonide might be given to you, maybe you've got a cough, and it aims to help resolve that cough a little bit faster. Next slide. So what are the side effects of these 4 drugs? So Paxlovid is most well known right now for giving a funny kind of metallic taste in the mouth. It starts a couple of hours after the first dose, and it continues about 8 to 10 hours after the last dose. That can come with some nausea and diarrhea. Remdesivir, because it's an infusion that's given an IV, an intravenous, an injection, you might get some warmth or pain where the infusion's going in, rash, headache, nausea. For fluvoxamine, you just get the typical antidepressant kind of side effects. So nausea, constipation, dry mouth, difficulty sleeping, feelings of nervousness. These are very common with most of the antidepressants. And then the budesonide inhaler, you might get a bit of a cough, throat irritation, thrush, hoarse voice. These are really common, like these are old meds. We've used budesonide for years. Those are really typical inhaler type side effects. Next slide. Okay. So this is the big question. A lot of people say, well, I'm vaccinated, and I don't really think it's very fair that unvaccinated people are prioritized for this treatment. So I want to explain to you how people are determined to benefit or be eligible or to need treatment. There was a clinical trial called the EPIC-HR trial. HR stands for high risk. This was the trial that was used by Health Canada to approve Paxlovid for use in COVID in Canada. So this trial, EPIC-HR, specifically looked at Paxlovid in people who are unvaccinated, not yet sick enough to need hospital care, so mild COVID, what we're talking about today. Also, no prior COVID infection, so no past immunity, not from a vaccine, not from a past infection, and at least one medical condition that would increase their risk of needing hospital care. So these were people who were at higher risk. That's why it was called the EPIC high risk study. And that the risk of hospitalization was probably about 6% for this group. So, a really common condition in this study was diabetes, for example. And what they found is that Paxlovid, when given to this population, when they still had mild symptoms within 5 days, reduced hospitalization and death by about 89%. So that's a pretty big number. And that's what, there's promise there. But the real trick is that most people are now vaccinated. So it's really hard to know how you take this study and apply it to a more general population. Next slide. So there's another study that they did called the EPIC-SR study, the standard risk study. Now, these were people who were unvaccinated as well, not yet hospitalized, no prior COVID infection, so very much the same, but didn't have that additional risk factor. So they were otherwise healthy. Or they were vaccinated, so this would have been 2 doses, and who had an underlying medical condition that increased their risk. So say vaccinated with diabetes. They released a preliminary analysis in December, and what it showed was that the main thing they were looking at is whether Paxlovid would help these people get better faster, and it didn't seem to do that. It was unclear if it reduced the need for hospitalization as well, and they haven't published these results. So what this really showed us was that we know that Paxlovid is going to help those people who are at highest risk, which includes people who are still not yet vaccinated or who could not be vaccinated. We're not really sure if it helps people who have lowered their risk so much by getting their vaccines. And that's why you'll sometimes see the treatments prioritized for people who are not yet vaccinated, as opposed to people who are fully vaccinated. Next slide. And that's what the Ontario Science Table did. So this is the guidance that a lot of the doctors will use and the pharmacists will use when deciding, whether someone would benefit and when talking with people. What you see is the science table said, okay, we know from the EPIC-HR study that people who have that kind of 6% risk of hospitalization or higher might benefit. So who are the people in our society who have that high risk still? So people who are unvaccinated, so especially people who are over 70 and unvaccinated, people who are pregnant and unvaccinated have very high risk of hospitalization. But also, people 40 to 69 who don't have a vaccine yet and have one condition, it could just be obesity, for example. And then younger people who have multiple health conditions. Similarly, people who are partially vaccinated, where they only have 1 or 2 doses, and depending on age, also have some additional risk factors, like could be obesity, diabetes, whatever. And people who are fully vaccinated, meaning that they've had their 2 doses, they've had their 3rd dose, some people are eligible for a 4th dose now. Those folks are probably, their risk is so low, they're unlikely to benefit much from treatment unless they're over the age of 70 and have multiple serious risk factors like obesity, diabetes, and heart disease, for example. Also, one of the groups that they say is generally offered treatment are people with a weakened immune system, because even though we can vaccinate, it's not really clear that the vaccine will help. It has helped as much as we need it to, so they opt for treatment. Next slide, please. Okay, so here's the timelines on starting Paxlovid. So the symptoms start on day 0. So we consider the day you feel that sore throat first, that's day 0. And you have until day 5 to take your first dose of Paxlovid. So in that time, you might be trying to get a test done, getting your medication list together. Your physician might need to send you for some blood work to check things like your kidney function to see if this is okay. There's a whole bunch of things that happen here. So you've got up until day 5 to start that treatment. There's a lot of drug interactions with Paxlovid that often require you to hold a medication or take half a dose of a medication or something like that. So you take your first day of Paxlovid treatment, you adjust your medication. So you stop your cholesterol pill, for example, for 5 days or whatever. You take your 5 days of treatment, you wait 2 more days, and then you restart all the meds the way you originally had them. So it's a little bit complicated. So what we're saying pharmacists sometimes do is blister packing medications to help people sort through these things, calling people on day 2 or 3 to check in to see how things are going, side effects, drug interactions, checking again at day 5, giving them a call to say, okay, did you know how to restart things the way we talked about? So there's a little bit of complexity here. Next slide. But the thing about it is there's complexity on kind of the clinician side of things, but once you're eligible and when you start taking this, it's actually very straightforward to take. It's 3 tablets you take in the morning and 3 tablets you take at night. You take 2 of the pink and 1 of the white in the morning, 2 of the pink and 1 of the white at night. You do this for 5 days. They come all blister packed like this. You take it with or without food, and it can be delivered to your home. You might be given a lower dose if you have poor kidney function, but that's again why we do blood work to look for that. Next slide. This is the list of medication interactions. So there's certain medications here, which are the black triangles, where you can't take Paxlovid. So people who take fentanyl, fentanyl for pain patches, street use of fentanyl, for example, certain long-acting antipsychotics that are injected, like risperidone. But then there's also some more common ones like carbamazepine for seizures or phenytoin. St. John's wort is also an herbal medication that means you cannot take Paxlovid, interestingly. There are some medications that while you're on Paxlovid, you have to hold, so you just don't take your other medication. So common cholesterol pills, there's certain ones like that. There's the odd inhaler. So your healthcare provider will actually go through your list and work through these things with you. There's a few medications too where you need to just take half of the dose or a quarter of the dose. So a common sleeping pill called Zopiclone, a common blood pressure pill called amlodipine. These are all things that are manageable. We just need a full list of everything that you're taking and then work with you to figure out what can be changed and what can't be changed. Next slide. So here's the questions I get most often. So do I need a positive test to get treatment? Yes, you need to be testing positive for COVID, whether it's on a rapid test or a PCR. If I get a positive rapid test at home, can I get treatment? Yes. You may be asked to do a PCR test to verify the result, especially if the clinician isn't 100% sure how you did the rapid test, or maybe it was left to sit too long or something. So don't be surprised if that happens. If I test positive but do not have symptoms, should I get treatment? Nope. You don't need treatment for asymptomatic COVID. This is for people who have mild symptoms, who were worried that those mild symptoms might become severe. Asymptomatic COVID doesn't tend to develop into severe COVID. If you test positive and have no symptoms, but develop symptoms, then you may become eligible for treatment. How quickly do I need to start Paxlovid? So we need our treatment. So Paxlovid starts in 5 days of symptoms starting. The other options, remdesivir, budesonide, fluvoxamine, can be started within 7 days of symptoms, 7 days of symptoms starting. Next slide. Are kids with mild COVID eligible for treatment? Not really. They might be given the budesonide inhaler, but generally the treatment, it's not approved in kids under the age of 18, so it would be off-label risk. But what you would do here is, serious health conditions like cancer, for example. Are pregnant people or people who are breastfeeding eligible? Possibly if they're unvaccinated or have a weakened immune system. With breastfeeding, you might have to pump and dump. Next slide. Are treatments free? Paxlovid and remdesivir are free. Fluvoxamine and budesonide have their regular prescription medications, so you don't have to pay for them. I live in a rural or remote community and don't have a car. Can I still get treatment? Yes, you can be assessed over the phone and treatment can be delivered to your home. Next slide. And what about if Paxlovid isn't an option? Well, that's when you might be offered remdesivir. It's an intravenous infusion given in a clinic or hospital. Each infusion lasts 30 minutes to 2 hours, and it's given every day for 3 days. So you can imagine it has some challenges with it as well. Next slide. So if you're not sick with COVID yet, but worried you'll need treatment, if you do get sick, what are things you can do now? Well, right now, the best thing to do is get all eligible vaccination doses. So age 5 to 11 can get up to 2 doses, 12 and older, 3, 60 and older, 4. People with a weakened immune system might be 4 to 5. If you have make sure you have a full list of your medications ready, including your herbal supplements. And if you're worried, talk to your primary care provider who might order lab work. If you haven't had it done in a while, you can get it done now, so it's ready if you do need this. Next slide. So here's my summary. Treatment helps people at highest risk of being hospitalized with COVID. Getting all eligible vaccines, including your boosters, lowers that risk a lot. Fully vaccinated people with a healthy immune system may not actually benefit from treatment, so just be aware of that. The goal of treatment is to help you stay out of hospital. There's no evidence right now that the treatment's going to help you be less contagious, get better faster, or prevent long COVID. Thank you.
That's great. Thank you, Kelly. And Sharon, for starting us off there. My name is Dr. David Sheik. I'm a family doctor from Guelph. Happy to be here tonight and share a little bit of my experience as a family doc in the community, as well as a doc that does a bit of work at our local assessment center in Guelph. And basically, myself and Dr. Gartner, who will be speaking shortly after me, we'll talk a little bit about what you should be considering if you are experiencing symptoms of COVID. Next slide, please. So just to set a little bit of the stage for this slide here, this slide talks about testing, mostly PCR testing, which is the testing that people have typically gone to the assessment centers to get over the last over 2 years as we've been working our way through this pandemic. It's the swab that goes right to the very back of the nose and is reasonably accurate at telling us whether individuals have COVID or not. In the early parts of the pandemic, we had been testing anybody who had symptoms at all, pretty much, and we're putting through pretty high volumes of people at the assessment centers. As was mentioned earlier in the presentation, there has been significant changes to who is eligible for testing, and it has swung from pretty much testing everybody with any symptoms to really limiting it to essentially frontline healthcare providers, first responders, individuals who live or work in high-risk settings like long-term care, retirement homes, congregate living centers, those sorts of settings. As well, pregnant women are encouraged to be tested if they are having symptoms of COVID-19, which are mostly cold symptoms. The reason for testing those folks is largely to enable them to perhaps get more quickly back to the workplace if they can confirm that it is not COVID that they have and that their symptoms resolve fairly quickly. So that's a part of the testing that's being done now. The other part that's evolved, which is what we're here for tonight, is that there actually is a role for testing for folks that might be eligible for treatment for COVID with the antivirals that we're talking about tonight. And so that's the top bullet on this slide here, that PCR testing is also available if you're being considered for the antiviral treatment. I'm going to just review briefly a little bit of what's already been touched on, particularly by Kelly. But for the most part, otherwise, young, healthy individuals who are fully vaccinated probably do not need a PCR test, and that's where we've moved to. So in the box at the bottom here, it says most people who have symptoms do not need or qualify for a PCR test. But high-risk high-risk contacts do not need or qualify for a PCR test. But the folks that might be eligible for testing should have one. Next slide. So this slide is the slide. Oh, yeah, there it is. So this slide here, we've seen parts of it, this section in here, as far as who qualifies for consideration for Paxlovid. But beneath here, you'll see a section down here about immunocompromised. So one of the first things that I'll try and assess to see if they're eligible for Paxlovid is if anybody is undergoing treatment for cancer. So if they are undergoing treatment for solid tumors or malignancy, or any lymphoid malignancies that may not actually be under active treatment. If you've had an organ transplant, like a kidney or liver transplant or a stem cell transplant, or if you're on any significant medications that suppress your immune system for any autoimmune sort of conditions. These individuals automatically, regardless of their vaccine status or their age, qualify to receive antiviral treatment. If you don't fall into this category of the immunocompromised, such as the cancer treatments, the transplants, or the immunosuppressing treatments, then we go by age and doses of vaccine. And we follow the same sort of table that Kelly presented just a short time ago. And I use this tool to decide whether somebody would be eligible for treatment or not. And it's basically just dependent upon age and number of vaccines. If it comes down to that somebody is not fully vaccinated or even has 0 vaccines, we look at the risk factors. And in this part of the form here, as Kelly had also mentioned earlier, there are conditions like obesity, diabetes, heart disease or hypertension, lung diseases like asthma or COPD, cerebral palsy or intellectual disability like Down syndrome, blood conditions like sickle cell disease or kidney or liver diseases that would qualify them for specific number of risk factors at certain ages to be eligible. So the bottom line, I think, would be that if you are unvaccinated, and Christina, you can put the rest of the presentation back up again. If you're unvaccinated or if you have a number of health conditions, it's worth reaching out to your family doctor or to your local assessment center to see if you qualify for the treatment. And as such, you would need a test to be tested. Now, if you have done a home test or have gotten a PCR test that is positive, you should be, if you don't qualify for the treatment, the bottom line is basically all you need to do is stay at home and isolate for the recommended time is 5 days from the onset of your symptoms, and as best as possible away from any family members that you're living with at the time. You should also be telling anybody that you've been in contact with in the previous couple of days that you have tested positive, and that they should be keeping an eye out for any symptoms as well. And the criteria for household contacts and whether they need to be isolating has changed a little bit over time. We used to tell everybody that they should be isolating if they're household contacts. Now, basically, if you are fully vaccinated and have no symptoms, as a household member, you do not necessarily need to isolate. However, if you're not fully vaccinated or if you have symptoms, then you should be isolating the same isolation period as what the person who originally tested positive is isolating for. Next slide. And just to remind everybody about the symptoms of COVID, it's the typical sort of cold symptoms, so cough, sore throat, runny nose, loss of taste and smell is one that sort of stands out in people's minds, would qualify as sort of mild symptoms. We consider it moderate if you have some more severe symptoms, such as actually being short of breath or having some confusion or perhaps being a bit dehydrated. And certainly more severe is if you're having significant trouble breathing and are feeling really unwell. And certainly in those situations, you should be getting assessed at an emergency department. Next slide. So basically, if you have mild symptoms, the recommendation would be just stay at home, essentially self-isolate. We treat symptoms. So if you're having a fever or feeling achy or sore, Tylenol, stay hydrated, so drink lots of water and fluids, and observe for any worsening sort of symptoms. Next slide. Moderate COVID, probably, and that's where you're developing more shortness of breath and have a little bit more severe symptoms, but you're not too bad. Being assessed at one of the assessment centers or getting in touch with your family doctor would be the right place to go there. And then, as already mentioned, if you have tested positive and you feel that you might be in that criteria where you might qualify for treatment, such that if you have a number of health conditions or if you've been unvaccinated, then you should be reaching out to your family doctor or an assessment center about possibly checking to see if you qualify for the antiviral treatments. So I'll maybe turn it over to Dr. Gardner now, and he works at the St. Mary's Assessment Center and has tons of experience about where things go after people have been determined that they are eligible for treatment. So Dr. Gardner.
Thanks, David. Yep, I work at the St. Mary's COVID Assessment Center. So there we are getting referrals from the community, from family physicians, from the Guelph General and Cambridge COVID assessment centers as well. And when we see people, we make the decisions at that time. Should we start Paxlovid? Should we start remdesivir? Should we do nothing? I will say that since the guidelines have widened a bit, we're having lots of discussions about who should and who shouldn't get Paxlovid therapy. The reality is most people in more of the moderate risk group that we're seeing, we've got time. Many people we see, they'll be within, say, day 2 of their symptoms, and they'll still be with mild symptoms. Many of these people, we will call back in a day or two and see how they're doing. And most of those individuals have improved by day 4. Those that aren't improving, then again, we talk about initiating Paxlovid treatment with them. The highest of the high risk that were outlined previously, we're pretty aggressive with prescriptions for them because, as Kelly said, they have up to 5, could be as high as 10% risk of admission. Whereas with the lower risk groups, we're probably looking at a 1 to 2% risk of admission at most. That doesn't mean that we're still not taking everyone's symptoms seriously. It just means that I think a lot of people come in with the expectations that they need to get this prescription when most people actually get better on their own. I'll emphasize again, the medications in the right people are helpful, but they don't get you better quicker. They don't treat any symptoms of long COVID. And I think that's about all I really have to add at this point in time. I'd be just mirroring everything that everyone else has said. The biggest risk people, the people we see in hospital right now, are the unvaccinated, those that are significantly immunosuppressed, the transplant patients, and lastly, those that are older with very limited functional capacity, those that have multiple medical problems in addition to their age. All right, thank you.
Thank you so much, Dr. Sheik and Dr. Gardner, Dr. Grindrod. As Dr. Lee mentioned, we'll go now to a Q&A, and we've received some questions before the town hall and some actually during the town hall. I would like to welcome Dr. Kevin Stinson, our WWIPAC lead from, and also an IPAC lead at St. Mary's, Kathleen Demers from the St. Mary's Assessment Center, and Vicki Murray, whom I'm sure our region knows quite well as Director of Pharmacy at KW Hospitals, but also, of course, someone who's been very involved with vaccine work. I have the first question for Dr. Stinson. I'm going to go through them quite quickly because I do want to make sure we get a lot in, if that's okay. So, Dr. Stinson, question from someone that came in before the town hall. Can I still catch COVID from my grandchildren who have all recently had COVID? Once they have tested negative again, can they carry enough viral load to infect others? And should I wear a mask indoors with them at this point?
Yeah, so using a test, what we would call a test of cure, so testing someone after they've been positive to see when they come up negative as a way of saying, are they still infectious, really isn't the best approach, especially if rapid antigen testing is the route, because we know that there's not a great sensitivity there. What we generally look for is most community dwelling people, if fully vaccinated, are no longer infectious, or are at least through the majority of their infectious period after 5 days, so long as symptoms are improving. And what we mean by improving is I no longer have a fever and I'm simply not getting worse, or things are staying more or less where they are for 24 hours or 48 hours if I've had any GI symptoms. There is a risk if you are personally someone who's severely immunocompromised or at higher risk of disease. There is a risk of that day 5 to day 10, where we would consider if you're going into higher risk setting, that person would still be required to wear a mask. So for example, in a hospital setting, we use 10 days for all of our patients because they're at a little bit of a higher risk. So for seeing your grandchildren, if they're at that day 5 to 10 window and you're at a higher risk of disease, it'd likely be good to hold off on seeing them, or if you do have to see them, have them and yourself wear a mask. Beyond that 10 days, so long as they've been improving, the risk is minimal, because at that point, there's not really enough infectious virus to be or to cause a concern.
Thank you so much, Dr. Stinson. Question, I think maybe Kelly, I might direct this to yourself or Vicki. What are alternative medications or vitamins that someone can take if they don't fall under the high risk category or they're not eligible for Paxlovid? Any comments on that?
It's that tincture of time they talk about. Sometimes you just got to wait it out. There are the symptom control though. So, if you've got a headache, Tylenol, add like over the counter, Advil, naproxen, whatever you would normally take for a headache, whatever you would normally take for a sore throat, any of those things, that's all the same. But there's nothing special, like there's a lot of questions and stuff online about certain vitamins and supplements. Really, there isn't evidence for a lot of this stuff. It can be expensive. It can have its own side effects. You don't want side effects when you're already feeling unwell. So I would really just stick to regular stuff you use for those regular situations, like Tylenol for a headache, for example. And Vicky, would you add anything to that?
Thank you, Kelly. Absolutely not. That's probably what I would have said as well. You want to be able to treat your symptoms. You want to make sure you're comfortable. And your local pharmacist can help walk you through some options if you need that. And I would follow what you would normally do for any cold symptoms.
Thanks. Really appreciate the advice. Question for Dr. Gardner. Do these antivirals like Paxlovid cost any money? Is it covered by my drug plan?
It is covered by the government. There's no costs incurred no costs incurred with Paxlovid or with remdesivir. There still will be costs incorporated if fluvoxamine or budesonide is prescribed. So most drug benefit programs will cover those latter two.
Okay, great. Question maybe for Dr. Sheik or Dr. Grindrod. Can COVID vaccines cause, so we're talking about vaccines, there's a vaccine question. Can COVID vaccines cause thrombocytopenia, which is low platelets and the sequelae of that? And if so, does this go away? Any takers for that one?
I'll jump in. So I'm certainly not an expert on this, but this is not something that I've heard as a significant concern. Low platelets or thrombocytopenia would be the term that we would use for that. I'm not aware of that being a significant issue with any of the vaccines. All of the vaccines are generally very well tolerated. And safe to use. There's very few instances where there would be what we consider a contraindication to using the vaccine. So my understanding is that I'm not aware of that being a significant problem, the low platelets. And maybe if Kelly had a comment or even Kevin,
I would just add to that, for example, like anything can cause anything in theory. So let's say that was something that happened coincidentally around the time you got the vaccine, or because of the vaccine. There are ways of investigating that. So, a referral to a hematologist. There are a lot of hematologists. So, on the Ontario Science Table, there are hematologists who've done a lot of work because AstraZeneca had that blood clot link. So you see a lot of groups like that very closely looking. There aren't specific concerns about these vaccines, but certainly if that's something that's happened with you, having a specialist assessment to maybe rule out other causes. That one of the risks we have sometimes is people attribute so much to the vaccination, they don't necessarily go looking for other actual causes for some of the conditions that they've got, and think there can be delays in diagnosis, for example. So I wouldn't necessarily rule it out. Anything's possible, but it's not a major common thing that we think of when we think of the vaccines. Dr. Stinson, do you want to add anything to that?
I think the only real thing to add is there was a lot of surveillance around this idea of vaccine-induced thrombocytopenia early on through the vaccine campaign. Well, I mean, the surveillance has continued right throughout, and it was a bigger issue associated with the AstraZeneca vaccine, and it was one of the reasons for pausing the AstraZeneca. But even looking at that, the incidence was actually still very, very low. It was around 1 in 50,000 doses, and so the risk is quite minimal, especially with that vaccine now pulled as a main vaccine of choice.
Thanks. That's really helpful context. I have a question maybe I'll put towards the physicians on the call. The question is, I have heard COVID is mild, but I do worry about ending up in the hospital. So will asking my doctor and getting a prescription for Paxlovid make me less likely to go to the hospital?
Well, I'll be the first one to chip in. Like I said, in even moderate risk people, the chance of ending up in hospital is extremely small with the Omicron. You're talking in the range of 1% or less. So if you're trying to take a medication that's going to reduce your risk from 1% to 0.5%, you're not really going to get a lot of bang, and you're likely going to be one of the 99.5 that it doesn't help at all. I certainly wouldn't take it prophylactically thinking I have a very mild course and I'll take it just in case. But I would say, again, there's a 5-day window to be able to take this medication. If you feel your symptoms are worsening within that 5-day window, please reach out. Please contact your personal physician or COVID assessment center and get looked at.
And I might just add in sort of a bit of my experience at the assessment center is sometimes patients come into the assessment center actually quite anxious about feeling a need or an urge to have to get this medication. They've heard about Paxlovid out there. They've heard there's an antiviral treatment for it, and they come in quite anxious about it. And they look great. Like they maybe had a runny nose or sore throat for a day or two. They did a rapid test at home. It was positive, and it's actually quite shocking for some people because they've gone 2 years and being really careful and not getting COVID for like 2 years through all of this. And now they get COVID sort of at this point, at the end, 2 or 3 years into it. And so it's a shock to them. So they come in and feel that there's a real need to get this treatment. But I was really kind of encouraged when I had sort of heard Dr. Gartner sort of present a couple of days ago on this, that, the vast majority of folks that actually are positive, and even if they do have a few risk factors and are a little bit older, actually will sail through this just fine. And it was reassuring to hear that it's okay to even wait maybe a couple of days and see how their symptoms kind of progress if you're catching them early on like day 1 or 2. Because if I make a referral over to Dr. Gardner to St. Mary's and he checks on the patient a couple of days later when they're at about day 4 or so to see how they're doing, sometimes, actually quite often, they may actually be almost feeling all better by that point. And there really is probably no need to go on a medication that might potentially give you side effects. You might have to go off of your other medication for a while if you're already kicking it on your own. So, anyways, I guess I just add that piece to it there. And then when we have that conversation at the assessment center, it does seem to bring the anxiety level down a little bit, actually quite a bit, I'd say, when they understand that, the bigger picture part to it there.
Thanks. And that actually answers a whole bunch of different questions that all kind of related to what should I do if I have a positive RAT, when should I call? So that was a really thorough answer. I do have I wanted to ask Kathleen from the assessment center side, is there anything that you wanted to add that you wanted community members to know in terms of their interaction with the assessment center, and any comments there?
Thank you very much, Dr. Ball. No, just if people are coming in, so they can book online for an in-person assessment if they feel the need, as per what Dr. Gartner and Dr. Schick said. So if they're coming in, just to recognize that they're going to need to be masked, that they will be directed straight into our clinic, into a bay. So there's not a lot of loitering around the hospital. Considering what's bringing them into the hospital, they will be escorted right in and be escorted out as well. So just keeping in mind that we don't have walk-ins, they're booked appointments to come in to see us. Many people are actually have been assessed in other venues, whether it's a family physician's office or another assessment center. So oftentimes the medication and the referral process is done virtually online through physician, pharmacy, and the other provider who referred in. So a lot of people are not actually coming into St. Mary's. But for those that do come in, to remember they will be masked, there will be hand hygiene, they'll be escorted straight into a bay, there won't be loitering around. If they're coming in for remdesivir, they will be there for a few hours. If we're doing blood work, and for an infusion that will last up to 60 minutes, and then monitoring afterwards. And so it's just to be patient. It's a busy clinic with a lot going on. So anybody can be coming into the hospital at this time. We just ask for their patience and their understanding. And we're always happy to take feedback from patients as well.
Thank you very much for that. I am going to pass it to my colleague, Dr. Lee. I know we've gone a little bit over, but great information.
Oh, thanks, Sharon. So I really didn't introduce myself. My name is Joe, and I work in a button factory. I also am the primary care lead for KW4 and chair the Ontario Health team in KW4. I really want to thank our amazing presenters and panelists for their expertise. And so what I gathered from all of you, vaccinations, it shouldn't be understated how important they really are to protecting us from COVID. And so vaccinations really are the big thing. We want people to catch up with the vaccines, get their boosters as appropriate. And there are these antivirals. They have their place. They really are placed for those who are at highest risk. And just to plead to everybody to show kindness to healthcare workers. Certainly our colleagues, all our healthcare colleagues, nurses, pharmacists, physicians, receptionists, so many other people have had a very tough time of things through this pandemic, and your kindness is very, very much appreciated. Besides our amazing panelists, I want to acknowledge our OHT administrators who have put together this, this webinar again, and in particular, the CND OHT administration. So Christina and Hava, kudos yet again. And finally, I want to thank you, the audience, for your kind attendance and participation. Wishing you safety, wellness, and a good night.